And as you know, healthcare has been in the news. Dan Walters mentioned the single payer issue. You know that Governor Newsom has promised to bring back the mandate for requiring people to purchase health insurance in California. During his State of the State address, in fact, the governor also noted that California had some of the lowest rates for Medicaid reimbursement. And then 2 lines later, he said that the state would expand Medicaid to everyone up to 26 years of age, including illegal immigrants. So how does that, from a free market standpoint, work? You want to raise your reimbursement rates because they're too low, but you're going to expand the number of people on the program. So how do you raise rates and expand the number of people on the program? Well, we couldn't have a better panel to talk about all the issues of healthcare and the free market solutions that can provide better healthcare without bankrupting the state. Moderating this panel, of course, is PRI's own Sally Pipes, President, CEO, and Thomas W. Smith Fellow on healthcare policy. And so Sally will introduce the panel.
Well, thank you, Dan, for that kind introduction. I'm going to say a few words. I could go on talking for hours about healthcare as a former Canadian who grew up under single payer and as a policy analyst on healthcare since the mid-'80s in Canada. But anyway, I thought what I would first do is just let people know what Medicare for all or single payer is. There are a lot of definitions out there for Medicare for all. Medicare buy-in at 50, Medicaid buy-in, Medicare for America, Medicare for all. But anyway, what single payer Medicare for all really means, the definition is there is one payer for healthcare, and that is the government. There is no private coverage allowed under a single payer system. And just yesterday in the House, Pramila Jayapal from Washington State and Debbie Dingell, the widow of John Dingell, one of Henry Miller's favorite people, introduced the Medicare for All Act, which is a single payer bill, no private coverage, and actually even more comprehensive than Bernie Sanders' 2017 bill, which is Bernie started all of this single-payer stuff back in 2016 when he was running against Hillary. It brought the issue up to here. He introduced S-1804 in October of 2017. He is probably going to introduce another single-payer bill, but as I say, Jayapal and Debbie Dingell introduced this bill yesterday without any cost estimate or any talk about how this bill would be paid for. It is more comprehensive than Canada's healthcare system because our Medicare for All system, which bans any private coverage for anything medically necessary, doesn't include dental care, it doesn't include free vision care, it doesn't include free drugs, and it doesn't include free long-term care. So this is going to be a very exciting battle on single payer between now and the 2020 election. There is dissension, I think, within the Democratic Party. The more moderate wing, it's hard to imagine a more moderate wing of the Democratic Party with people like Nancy Pelosi coming out today and saying she is not for single payer. She's actually for a stepping stone approach by beefing up Obamacare, maybe the public option, which was in the original Affordable Care Act. She is for that. But I find it amazing that I'm saying that she is considered more moderate on healthcare. But all of the plans, whether it's Nancy Pelosi or the people, Debbie Stabenow, from also Senator from Michigan, and Tammy Baldwin from Wisconsin, they are all pushing these sort of stepping stone approaches to single payer. But rest assured, they are all stepping stones to single payer. Bernie Sanders never talked about what his bill would cost when he was running against Hillary. He never said what it would cost when he introduced his bill in 2017, but the Urban Institute, not a conservative free market organization, and Charles Blehaus from Mercatus both costed his bill, S-1804, out at $32.6 trillion over 10 years. That's $3.2 trillion a year, which is what America spends on healthcare in total today. And I can tell you, as someone who's been watching healthcare for many, many years, that this, if any of these bills become the law, $3.2 trillion a year is just a small number, because it'll be a lot more expensive. If you look at Medicare, which came into being under President Johnson in 1965, they predicted that it would cost $3 billion in the first year, and it would cost $12 billion by 1990. In effect, Medicare in 1990 cost $105 billion. So these numbers that are being bounced around, I think, are low. And when people think something is free, they will demand a lot more of it. So that's what's happening at the federal level. It's a big issue. I have a new book coming out in January called False Promise, The Disastrous Reality of Medicare for All by Encounter Books, so stay tuned on that. As Dan said, Gavin Newsom has not been able and has decided not to introduce to really support single payer at this time. Not a single Democrat introduced a single payer bill by the deadline on last Friday, February 22nd. He did, I think, get a lot of votes because he promised the National Nurses United a very aggressive lobby for single payer. He promised them that he would introduce single payer. But instead, in his inauguration, he came out with a few ideas. One was, of course, increasing the age limit up from 19 to 26 for people, undocumented immigrants in particular, to be eligible for Medi-Cal, our state Medicaid program. And as Dan said, the reimbursement rates for Medicaid are low in this state, but 1/3 of the population of California, 13 out of 39 million Californians, are on Medi-Cal. We've seen emergency room use go up because although these people have Medi-Cal coverage, doctors are not taking Medi-Cal patients because of the low reimbursement rates. Governor Newsom did ask the White House and the Congress if they would approve sending these federal funds back to California so that they could implement a single payer system. I say there is no way that the Trump administration or the president or Congress are going to give those funds back to California. And with the president being a Republican, the Senate being Republican controlled, this is just not going to happen. But this is, I think, single payer is going to be the key issue in that 2020 election. Governor Newsom also is a big fan of bringing the individual mandate into the state of California. As you know, it was eliminated under the tax bill in December of 2017 and had expired as of January 1st this year. The CBO had said when they costed out what would happen to the uninsured population if we got rid of the individual mandate. They said 14 million Americans would lose their coverage if we got rid of the mandate. The CBO just came out with their their tail between their legs, saying, "Oh, the number 2.5 million." So they grossly overestimated the impact of an individual mandate. But Gavin Newsom is for the individual mandate. He is for increasing the age to 26, adding 138,000 people to our Medi-Cal rolls. And the third thing is he's upped the level for the people to get the subsidies on the California exchange called Covered California, so that Californians would be the individual Californian, the income level being eligible for a subsidy, 78,000, and so much higher than at the federal level, where the individual is 48,000 and 98,000 for a family. So I think there's a lot going on here. How would Governor Newsom pay for this? The cost of these programs he's talking about, $500 million. Where would he get that money? Well, he says he would get it by the funds they would get in from the penalties from introducing a individual mandate in California. So this is what he's planning. I don't know. As I say, there isn't a single payer bill around right now, but Tim says there could be an emergency single payer bill come in, because I know the nurses are going to be furious because they back Newsom and single payer is not on the ballot right now. I think Californians are safe from a takeover of single payer at this moment until the 2020 presidential election. New York State is also pushing. They've got a New York Health Act. They now have the governorship, the Senate, and the Assembly in New York, so we'll see what happens in New York State. As a former Canadian who developed a project at the Fraser Institute in Canada back in the late 80s, Waiting Your Turn, a guide to hospital waiting lists, and now in the 2018 numbers that came out from Fraser, the average Canadian family waits 19.8 weeks, 5 months, from seeing a primary care doctor to getting treatment by a specialist. The care is rationed. It is not free. The average Canadian family pays $13,000 a year in hidden taxes for a healthcare system where you have to wait and your care is rationed. And there is a doctor shortage. And when you look at Bernie's plan and you look at Ms. Jayapal's plan, there will also be, if we get this, we'll have long waits, rationed care, new and higher taxes to pay for this program, and there will be a doctor shortage. We already saw a number of docs retire early from practicing, excuse me, when Obamacare came into being because of the regulations, the paperwork, all of that. Well, under Bernie's plan and Jayapal's plan, doctors would be reimbursed at Medicare rates 40% below what they get paid for treating private patients. So you're going to see a lot of the best docs, in particular specialists, getting out of the practice of medicine, retiring. And my biggest worry is that the best and brightest students will not go into medicine if they think they're going to be public servants and their salaries are going to be controlled by government. Canadians have an escape valve. 63,000 Canadians cross the border each year, come into the United States, and pay out of pocket for MRI scans, positron emission tomography scans, shoulder replacements, heart bypass surgery. All of these things, when you're told that the wait on average from seeing a primary care doc to getting treatment by a specialist is 5 months. Back in 1993, that number was only 9.3 weeks. So my job is to educate the American people and people in California what it means for if you have single payer. Ration care, again, long waits, new and higher taxes, doctor shortage, and Bernie and Jayapal say no referrals to specialists. Well, a country like Canada, the UK, you can't have a healthcare system that's run by the government if you don't have a referral system, because everybody will want to call up their cardiologist, their ophthalmologist, and there'd just be too much demand and very little supply. So that is the Canadian system. I have to move on because I have to introduce our two next panelists. But as I like to say, my great humorous friend, PJ O'Rourke, says, if you think healthcare is expensive now, just wait until it's free. And as Seema Verma, the administrator of Centers for Medicare and Medicaid Services said, Medicare for all will be Medicare for none. So the American people need to know what it means if government fully takes over their healthcare system. So thank you. And I'd now like to introduce our two panelists. Henry, would you like to go first? Dr. Henry Miller. He is Senior Fellow at Pacific Research Institute. He joined us last September, but I've been a friend of Henry's forever and a day, and he does so much great work on biologics, on GMOs, on the whole new, the Green New Energy Bill. Henry is just a wealth of knowledge on these subjects. So please welcome Henry Miller to the podium, and then I will introduce Wayne.
I want to pick up first on something that Tim Anaya said in his introductory remarks this morning. He said that free market ideas can attract unusual, unobvious coalitions. And I think, I hope my remarks to you today will suggest one that might come to exist between us conservatives and those of a different persuasion who claim to be concerned about those who are most vulnerable in our society. And you can get a hint of that in the title, Why a Little Overregulation is a Big Deal, because it hurts the poor the most. I'm going to talk about, I'm a recovering regulator, which Sally didn't mention. I was at the Food and Drug Administration for 15 years, where I was the biotechnology czar. and the medical reviewer of the first biopharmaceuticals. So if any of you take human insulin or know somebody who does, that was a product that I and my team approved in record time, marked record time in 1982. Purposes of government regulation are numerous, and here are a few of the salient ones. Human and animal health and safety, environmental protection, ensuring accuracy of information to consumers. Without accurate information, you really don't have market forces working properly. Fair competition, and better quality of life. Now, there are a couple of general ways that regulation of all sorts of things can be approached. One is anticipation. It seeks zero risk, tries to prevent any and every harmful eventuality. It's costly and inhibits innovation. And this is pretty much the European model. It's also known as the precautionary principle. And so products like pesticides and genetically engineered organisms, so-called GMOs, are regulated so stringently, so conservatively in Europe that these products virtually don't exist. So Europe has imposed a ban on the most effective, safest, state-of-the-art pesticides called neonicotinoids, which has really disadvantaged European farmers and has them in a panic. Genetically engineered organisms are not grown in Europe virtually at all. There's one variety of corn that's grown in Spain, but paradoxically, Europe doesn't permit these products to be cultivated, but they allow them to be imported in foodstuffs, which is sort of the worst of all worlds. A second approach to regulation generally is resilience, seeking to eliminate unreasonable risks. And that's pretty much what we do in the US, or claim to do. There are a lot of unfortunate exceptions to that, but that's a more reasonable approach because it promotes or permits innovation and with all of the advantages that pertain to innovation. Now, costs of regulation are monumental, and I put in the zeros here in order to remind you of how monumental. Compliance with federal regulations overall is about $2 trillion annually. That's probably even an underestimate. Compliance with EPA regulation alone is on the order of $330 billion. And the last line is not directly comparable to the upper two because that's not compliance costs. That's just a reminder of how ubiquitous FDA regulation is. FDA-regulated products account for some $1 trillion of consumer products. And these range from X-ray equipment to food, drugs, biologicals, vaccines, and even, if you can believe it, microwave ovens for historical reasons. So these costs are massive, and they have important implications because, of course, they're passed on inevitably to consumers. Now, the income effect is something that is not widely understood or appreciated, but depriving citizens of income has an effect on health. There is a direct relationship between health and wealth. Deprive an individual or a community of wealth, you have worse health. So it's no coincidence that the wealthiest California county is also the healthiest, with greatest longevity and best health, and that happens to be Marin, north of San Francisco. Academic studies indicate that by depriving a community, a population of roughly $7 to $10 million in regulatory costs, causes one excess death. And we'll use the $10 million figure, more conservative one, just for ease of calculation. EPA's $330 billion cost of compliance, which again is passed along to consumers inevitably, causes potentially 330,000 deaths. Now, so by imposing such huge costs, you begin with what amounts to a deficit, a cost of 330,000 deaths. So you need to make sure that the benefits, whether they're tangible or intangible, health-related, any of those reasons for regulation, targets for regulation that I showed on the first slide, the benefits need to be commensurate with this kind of potential cost. And that last line is really the key. And I used that example of EPA just as an exemplar because the number is so high. But it illustrates how we really need to make sure that there are benefits, cost-effective benefits from government regulation. So there are some regulations that are highly cost-effective, as studies show. The requirement for automobiles to have shoulder harnesses, very cost-effective. Others are not so cost-effective. One of the least is an interesting one that was published in a rule last November that requires a federal regulation from USDA that requires the labeling of so-called bioengineered foods. The definition in the rule is virtually incomprehensible, even for those of us who have been involved in the field for decades. And in the rule, which runs 237 pages, by the way, and is totally, utterly, completely unnecessary, as the scientific consensus would tell you. They do a cost-benefit analysis of sorts. The initial implementation costs of this rule for bioengineered food labeling will be on the order of $3 billion. And then the ongoing costs of enforcement and providing information to the public will be on the order of $100 million annually, as the rule says, in perpetuity. And so what we have is using that $10 million causing one excess death figure, we're going to have an initial cost of roughly 3,000 deaths and about 10 deaths per year ongoing. Now, what makes those numbers especially poignant is that the rule, after doing this cost-benefit analysis, has a sentence that says, we do not anticipate any benefits to human health or the environment from this rule. So it's funny, but it's not funny when you consider the costs to innovation and to the well-being of Americans with respect to a totally unnecessary, incomprehensible rule that will be of benefit only to USDA bureaucrats and to tort lawyers. Now, how does regulation discriminate against the poor? This is a quote from a paper by Diana Thomas, an economist at the University of Utah. People make private decisions determining their diets, how safe of a car to buy, whether to install smoke detectors, the type of neighborhood in which to live, and counseling for drug and alcohol problems. As regulatory agencies address smaller and smaller risks, thereby driving up the prices of many consumer goods, they crowd out expenditures people would make in their private lives that address larger risks and perhaps cost less than government regulation. So this goes directly to the freedom to make our own choices, and also, as you'll see on the next slide, to why this is particularly a problem for the most vulnerable, the poorest in our society. By focusing on the mitigation of low probability risks with higher costs, Regulation reflects the preferences of high-income households and effectively redistributes wealth from the poor to the middle class and the rich. In other words, regulatory costs are regressive, and the impacts of them are felt most by the poorest. So, in conclusion, I want to leave you with unneeded regulation is what has been called statistical murder. Regulatory costs are regressive, and so regulation must be imposed judiciously. It has to be cost effective. It has to warrant the income effect on longevity and health that we see from the costs of regulation, or for that matter, on taxation. One of the reasons that, one of the corollaries of this is that oversight by the Congress over regulatory agencies is inadequate. Congress has really been asleep at the switch. And an interesting example of that is yesterday, and I think today, the House Oversight Committee has been perseverating about Michael Cohen and what he can tell them that's salacious about the president instead of carrying out their main function, which is oversight of federal agencies. So I'll leave you with that. I'd be glad to entertain questions. Are you going to take them now or
At the end.
At the end? Okay. Thank you very much.
Thank you, Henry. And now I'd like to introduce our third panelist, Dr. Wayne Winegarden, who is a senior fellow at PRI and is very prolific on studies, op-eds, columns, interviews in the area of pharmaceutical pricing, the whole issue of which is so in the news today. And I'm very excited to announce that PRI is going to launch later in March our new Center for Medical Economics and Innovation, and Wayne and Henry are both going to be very involved in this new but important event, in particular because there are some organizations like ICER that are sort of have taken the lead, but which are similar to NICE in the UK, where government officials would be able to determine whether you are qualified to get a new drug based on your age. So there's a lot going on. So there's no end of work that Wayne and Henry are going to be able to do. So please welcome Dr. Wayne Winegarden.
I got it. It's okay. I have slides too. I'm going to show you my pictures. It's right, this one. What I wanted to do, especially I guess in light of our new Center for Medical Economics and Innovation, and if you talk about the front lines, I guess you could say of the healthcare debate right now, it really is around drug pricing, because we obviously know that pharmaceutical products are what's driving the unaffordability problem in healthcare, except for, of course, that's not what's happening at all. And I think it's important to focus on first, kind of what do we do right in the U.S., because when you look at the debate right now and what we need to do with pharmaceuticals, no one ever talks about what's good about the system, because you can't fix something if you don't know the positives and the negatives. And I think the whole issue of access, right, and that gets to improvements in quality of life, cures, things that actually, improve our health, right? If you look at access to the most cutting-edge medicines, and that's what this chart here is showing. You can see the U.S. is the orange, so we can kind of clearly see, and we're almost at 90% of all the new medicines that were introduced between 2011 and 2017. So we had access to 90% of all those medicines. All the other systems have some sort of control, some sort of access, single payer, kind of like what Governor Newsom wants to do with Medicaid. Right? He's going to create a dual system here in California. Look at Canada, right? Because Canada is the savior for the U.S., right? We're going to buy all our drugs from Canada, except for you can only get half the drugs you need or we have currently access to if we bought them from Canada. 48% of all the new drugs Canadians had access to that. So what does our system do well? We actually have access to all the new cures, all the innovations, all of the promise that these new medicines bring. We have access to that, and the rest of the world doesn't. Okay. And I think that's important in terms of the initial framework. When we're level setting, I think it's also important, are pharmaceutical products driving the inflation problem? right? And if we look at, I think constantly, one of the ways we constantly do it is, oh, well, we spend so much more per drugs here in the U.S. relative to the rest of the world. And that is 100% true. The third bar on the right, it only goes to 2016. Our expenditures on drugs here in the U.S. is 112% compared to the rest of the world. I apologize, it's early, there's lots of numbers, but we'll get through it. So 112% for the pharmaceuticals, which is actually less than we have actually up to 2017 data for total health expenditures, right? It's 160% for total health expenditures. So yes, when you look at health expenditures, pharmaceutical expenditures, we spend a lot more than the rest of the world. If you looked at doctor expenditures, hospital expenditures, we spend a lot more too. And you can see that data also if you look at the latest pricing changes, right? So the column all the way to the left, that's what happened last year. Total health expenditures grew about 4%, 3.9. Pharmaceutical prescription drugs grew at 1/10 that rate. So we're talking about how we have to control pharmaceutical prices, but expenditures didn't go up, right? Now, over the past 5 years, 2013 to 2017, it did. And that was also a period where, we actually cured hepatitis C. So you would expect expenditures to go up. And when you start going to the longer terms, 10 years, 50 years, what you get is exactly what you would expect, which is a product that's a complement to other kind of healthcare services and a substitute, right? They all work together. It all kind of grows at the same rate. We have a really bad healthcare affordability problem, and California has to address it, the federal government has to address it, but we have to address the systematic problem, which is with healthcare affordability, not necessarily with prescription drugs. But there's also a problem with all of these numbers, and that's kind of what I want to spend a good bit of the few minutes I have with you talking about, because you see in the newspapers all of these stories of 20, 30% price increases. Insulin is now 5,000 times the price of what it used to be. And so, how do we actually reconcile these issues, these trends? And that's what this really ugly kind of math that I'm going to make you do first thing in the morning. But it gets to, I think, a really important issue. So when you look at the pharmaceutical market and how that whole process works, it starts when manufacturers set a list price, just like any other company. And so in this example, we're going to say they have a $300 list price for their drug. Okay. Now, if you're a patient and you go to the pharmacy counter, you're going to buy your medicine, right? Most people have some sort of co-insurance. 25% rate is not an unreasonable rate. So if the list price is $300, you as a patient have to pay $75. Okay. And these list prices are what you see in the paper. These are what all the stories are going about. These are the prices that are growing at double-digit rates, and that's a big part of the problem. Right? The catch is, and which is why we have only a 0.4% growth in expenditures, is that discounts have been growing at a faster rate. So what you have is a very complicated system. So you have the manufacturers and you have insurers, and the insurers hire people called pharmacy benefit managers or PBMs, and they negotiate on their behalf to get a discount that goes through the system. But the patient is outside of that. So what happens is you get a discount off that $300, and actually the net price is only $120. Right? Now the insurer, he's like, oh, I only have to pay $120, but the patient, he pays $75. So now, even though the patient has a quote-unquote 25% co-insurance, he's actually paying the lion's share of the costs. So the insurer is only paying $45. The manufacturer is only getting $120. Right? So when the manufacturer, they say prices are going up, they're saying, well, no, my revenues are only at $120. When you look at the the PBMs, they're saying, look, we're creating great savings into the system. And you're looking at the patient, and the patient saying, my costs are going up, and especially when you talk about some of these new, biologic medicines that cost $10,000, $20,000, 25% can be, that's a nice chunk of change. And I think that's part of the problem that we need to address. And so when we're talking about how do we fix the kind of affordability problem of prescription drugs, the first thing is to recognize that there's a systemic problem, and you're not going to fix the problem until you address our healthcare system, and that's what Sally can solve for us. Right. But we have issues within the healthcare, the prescription part of it that we also need to address. And this is I'd say the first area that we need to look at. Okay. And the problem is when you look at Governor Newsom's proposal in terms of trying to move towards single payer, right? And personally believe that this is the camel's nose under the tent. If you believe that he's just going to stop at consolidating drug purchases within Medicaid, then I have a bridge to sell you in San Francisco. This is the beginning, and the problem is, one, you're not going to solve that fundamental problem, right? We're not going to solve that problem of how do we fix the pricing system. We're not going to solve the problem of we don't want necessarily lower drug costs. We actually want less expensive, higher quality healthcare. Right? I mean, if you do the math on it, right, if we double our pharmaceutical expenditures but have the amount of total healthcare spending we have, pharmaceutical share is going to skyrocket. That's not necessarily a bad thing, right? Or if we improve quality of life, that's kind of what we're supposed to do. Modern medicine is expensive, and that's not necessarily a bad thing. And solving that is not monopolizing it into the state. It's by creating better competition and eliminating these incentives, these disincentives. I need to make a note, just because we always talk about Canada, and California rarely, certainly on the, rarely sees a bad idea that it doesn't try to implement, and I'm surprised you haven't brought back the whole importation issue. But if we go back to Canada, 48% compared to 90%, so we can't get all our drugs from Canada. But also the population of California, right, is larger than the population of Canada. So how on earth can they actually, fund the California or supply the California market, let alone the entire United States? So the problem is we don't have, in all of these policies, serious solutions. Now, there has been one good solution out of HHS, right, where they actually directly get at this issue, where they're saying, hey, look, and I won't bore you with the details, but if you want to talk offline about it, we can. But basically what they're doing is they're taking the discount and they're saying, hey, wait a second. If there's a discount, it's got to get to the patient. It doesn't make sense that if markets have one price, not two, right? So the price of the drugs is $120 after discounts. That's where we need the patient to be involved in that discount. And it rebalances out. And I think that's a very important step. The Secretary Azar's proposal can only do that in the Medicare market and some Medicaid programs. We need the Congress to pick up and do this so we can get into employer-sponsored plans. California can pick up on this idea, and we need this concept to be kind of implemented more widely. The idea that if there's going to be a discount, it's got to be at the patient level. We can't have this convoluted system, right, that has two prices that distorts the concept of a market and say, oh, we have a good market-based system. It makes no sense. What we also need to do is promote, and this gets to the whole regulatory issue, right? In the U.S., there's two, well, actually in the world, there's two types of medicines out there. I'm being a little kind of simplification here. We have biologics, and we have that kind of the traditional kind of chemical-based medicines, right? There's chemical-based medicines, those are the generics, your statins, the things that we kind of take for granted. The generic market's 90% of that in the U.S. compared to 40, 50, 60% in the world. So we have a great use of the market to bring down the costs of the kind of the typical medicine that you get at the pharmacy counter. Where all the excitement is in the kind of the life sciences industry is on what's called biological medicines. These are actually, it's kind of creepy, but these are actually biological processes that we use to create medicines. So instead of being a chemical compound, these are live organisms that we use to treat, in this case we have Remicade, which treats all sorts of autoimmune disorders. So rheumatoid arthritis, Crohn's disease, all of these just horrific diseases, they actually have new therapies coming out all the time. And this is where the excitement is, and this is where the new cure, right, Sovaldi, the new cure for hepatitis C, $84,000, this is a biological medicine, right? And so what we really need is an advanced biosimilar market, a very strong biosimilar market, competitive, right, the whole way the market's supposed to work. You have a monopoly for a short period of time to reward the innovation, and then you have lots of competition to drive down prices. It's the way the system's supposed to work. And that's not working right now in the U.S., and that's a regulatory issue. If the FDA is not approving these fast enough, the structure of the system is biased against biosimilars. And what we did is we did an analysis that looked at, well, how much can you really systematically save? And that's what these kind of numbers, and I'm just going to skip to the end result, which is that third column, actually. We're talking about, let's say, if we can get biosimilars up from, instead of actually around 10% of the market, which is where we are now, to even 50, right, compared to 90% for generics, even 50, Medicare can save $150 million, right? The employer-sponsored plans can spend, at that point, $300 million. So we're talking about almost $500 million of savings to the healthcare system, right, from creating more kind of a more robust biosimilar market and getting more of these biosimilars in. In the US, we have 17 biosimilars approved. In Europe, they have 58. So compared to generics, where we're leading, and that's actually driving down our price. And if we remember the OECD comparison, right, where we're at 112 for pharmaceuticals versus 160 overall, that has a lot to do with the much stronger generic market we have here. But we have, in the medicines that matter, in the new innovative medicines, the ones that are the most expensive, we're lagging. Right? And part of the reason we're lagging, again, it's the same thing with the pricing issue. It's the system, it's the incentives. Whenever you see, in any market, if you see an adverse outcome or something that doesn't make sense, it probably does make sense. You have to find out what's wrong with the incentives. And with the biosimilars, we have all sorts of practices that disincent the use of biosimilars. So one of the things they have is what's called buy and bill, right? Where the practice buys a medicine, $10,000, $20,000 from the manufacturer. When they administer it to the patient, you then bill the insurer, and your bill is a percentage of the cost. Well, if you sit back and think about it, if a biosimilar is about 30% less expensive, which is about what it is, and you have a $10,000 drug and you have a $7,000 drug, and your compensation is based off of a percentage, and it's the same percentage, you know where this is going. Your incentive as a practice is to use the more expensive product. Same thing, they have policies that says fail first. Many payers force patients to first fail on the more expensive biologic before they can even get prescribed the lower price biosimilar. So the policy makes no sense. And so these are the changes that we need to make. Continued kind of FDA has to get a more robust and solution to how we get biosimilars out there. And this doesn't just matter for the federal level, which is where a lot of discussion is. This also matters for California, right? If we're talking about how the costs on California's state Medicaid program are going to kind of prolong, if we can get just the 500, whether you're talking about 150 billion in savings for Medicare, and they say California, let's say is 1/10 of that, so $15 billion for just one drug, but we can get that over 58 drugs. Now you're talking about real money. Now you're talking about real savings. So anything that we can do that can encourage those types of policies that will actually bring more biosimilars into the market. Again, it's a market-based solution to help bring down those costs. And I'm guessing this is the kind of the gong show cane, so I'm going to end here, but thank you very much.
Right.